with us Dr. Baidurjaya Bhattacharjee. Sir is a research officer, homeopathy, and scientist one at the Central Council for Research in Homeopathy. Sir has vast research experience with the published around 15 research papers published in various national and international journals, and he has also received multiple awards. And he is also a reviewer of indexed peer-reviewed journals like Complementary Medicine Research, Journal of Integrative and Complementary Medicine, Alternative Therapies in Health and Medicine, to name a few. Over to you, sir.
Thank you very much. So it has been a very tiring day for all of you. So as we have come to teach you about the standard treatment guidelines, what we have been told to do, and we are given the tough responsibility to teach the clinicians. We being the researchers mostly involved in clinical or fundamental or some kind of research, and we are coming here today to teach the clinicians. So that is a very exciting thing. So I would also like to get something back from you all. So we are having a audience which is representative of the whole country, and I would like to, as we know that the scenario of homeopathic treatment is different in different parts of the country, and I would like to know from the different parts, where do the people come for treatment of metabolic disorders, where do they trust homeopathy, and where does that trust ends? So anyone may start. We can start from Northeast, who are there, because I was posted in Mizoram for 2 years. So anyone from the Northeast can, yes sir, please.
Hepatitis antigen level is decreased by combined medicine, which was not found by allopathic medicine.
Okay.
And diabetes is a very common, dyslipidemia is a very common, and result is miraculous result. I have seen miraculous result, but one thing is that don't trust the mother tincture. Go for constitutional medicine. Mother tincture is temporary relief. Patient will take this medicine for 5 months, 6 months. After that, he reported, sir, आपका medicine जब तक खाया था फिर वही है, फिर हम एलोपैथी शुरू कर दिया. But once you treat the patient with a constitutional medicine, this medicine will get the permanent result. Along with diet modification is very, very essential. Two things you have to remember in mind.
Where
medicine along with. What?
Where does the people stop trusting homeopathy? When?
पेशेंट को अल्टरनेट ढूंढ रहा है, हम सर्विस नहीं दे रहा है.
थैंक यू सर. एनीवन एल्स? कश्मीर से कौन आप लोग आए हैं? आपका थोड़ा एक्सपीरियंस बताइए.
जी, मोस्ट ऑफ द केसेस आई एम वर्किंग इन द गवर्नमेंट मेडिकल कॉलेज, एलोपैथिक मेडिकल कॉलेज. मोस्ट ऑफ द केसेस आई वर्क विद MD, DM allopathic, but most of the time they used to pull the legs out of the homeopathy. That part should be covered. That part should be covered. There should be some reference from the both sides. If I am going to refer, they should also refer. There should be some guidelines on that levels.
Definitely, sir. Anyone from the southern part of the country? Yes, please.
Myself, Dr. Ying. I'm from Nagaland. I'm working under Nagaland government NBACTC since 1 year. One practical issue that I'm facing is some cases are very managed very easily, but some very difficult to manage. And one issue, main issue that I'm facing is some company they label indication like so and so remedy for healthy heart, so and so for diabetes. So patient tends to purchase that outside online.
Over the counter.
Yes, over the counter. Okay. So I feel this issue, if we can resolve, like asking them not to label the indication so that they won't self-medicate, especially the drops and mother tincture.
It's very difficult from the part of the homeopathy because single remedy has many uses. Anyone else from here? Yes. हाँ.
Interrupt our previous sir. He was saying that we should not totally don't give mother tincture. Actually, I feel I came from Tripura, Agartala. Me too, I am practicing in government sector since 15 years. So in some of the cases, we feel that to gain the confidence at that, at the first knot, we have to give mother tincture. Like, no, you said, sir, that we should not give mother tincture. But I said, just, sir, just a second. I just let me complete my speech. No, sir. Actually, see, sir, the patient are going from paracetamol. Suppose a patient is having pyrexia, he or she came that I want to get the quick relief like paracetamol. So to prove the etiquette, the authenticity and the magic of that homeopathy, in that, for instance, if we give eucalyptus mother tincture in the spot, the fever diminishes. Though, and the Raulfia mother instantly can diminish the pressure. But to gain that confidence of that patient, sometimes we have to go for mother tincture, and what we say that it is the palliative. If you depend always on the authenticity, that the single, that the red line, then the homeopathy, I don't think in that modern time we can survive in the field of modern science. We have to do something, and some of the times we have to take the help of all the the palliative drugs and all the syrups and all. We have to, because I think that the first priority is to save and to just get that picture of our homeopathy in the front, because by practicing the single 111, we are always in the, we have to sui se sui ko aise we have to go. Means to kill that drugs, we have to give that drugs. I feel it is my opinion.
Yes,
I don't.
yes, you can have your opinion. I was Dr. Nilanjan.
Thank you, Dr. Bhattacharjee. Actually, I heard Madam and Sir, both are correct. Both have the individualistic approach and opinions. Both are correct in their part. But one thing is, we have to consider, we generally have a tendency to prescribe the mother tinctures in material doses and for days together. We have to control, as Madam was telling in previous session, we have to give a controlled dosage and to avoid the cumulative effects. For example, I have seen personally, and there are also research papers, that Raulfia mother, it is a common practice to prescribe Raulfia as the first line of drug, mother tincture, for several days. It should not be prescribed. I personally and one of my fellow colleague PGTs, while I was doing MD, he had done his dissertation with Raulfia 30. In my clinical experience, I have seen excellent results with Raulfia 30 being the hypertensive, anti-hypertensive effect within a very few days. If you go in our literature, with our stalwarts, you can recall Dr. R.T. Cooper. His references many references are given in his writings and also cited by Dr. J.H. Clark in his Materia Medica. He used to prescribe the mother tinctures in single doses. And in infrequent, for example, in single dose, he used to prescribe, and for days or months together, he used to wait, just like we prescribe and wait in case of centesimal or other potencies. He used to wait, and he used to get good results. So we have to evaluate, and we have to search our literatures, as well as we have to evaluate what we are facing in our practice, and we have to build a cumulative effect. That's why I am telling that I have a personal suggestion that this is a very, very effective program. I have never attended such an effective program, with such good interactions and outcome. I would suggest that we have created a WhatsApp group. I would suggest everyone to join that group and to continue this, because we have to interact not just for today. Today we may be meeting here. We don't know. We have to interact. We can interact in near future, or we may interact with each other. It will be very effective if we maintain that group. Okay. Thank
It is a very good proposal actually, because professional interaction is one of the best ways to learn. Yes. I'm just keeping the mic here. And the biggest challenge in the metabolic disorders, the biggest dilemma, that in most of the cases we don't have a clear-cut presentation of these diseases. This is the most difficult part of the treatment. Except whatever has been taught today, gout is one of the conditions where we can have some kind of things like there is a pain in the joint or others like that. But in all the other disease conditions, especially related to fat and carbohydrate metabolism, we cannot find a clear-cut picture, and that becomes the biggest challenge. Most of the cases, the patient walks in your clinic, doctor, I did a routine blood test, because nowadays accessible healthcare is one of the millennium and the sustainable development goals of WHO and all countries of the world. And so everyone has accessible investigation, accessible healthcare. Everyone is conducting tests 6 monthly, yearly. They're coming with the reports, and once the reports are in hand, either cholesterol is raised or there is some aberration in the dysglycemia. I will not say diabetes, there is a dysglycemia condition which is noted by the patient. And this is a very common finding. Patients come to us, they say, doctor, I am having this, do something to me. They come to a homeopathic physician. What I personally feel, doctor, I don't want to take allopathic medicine. That is the first criteria. They come to a homeopathic physician. I don't want to take allopathic medicine. First of all, allopathic medicine is costly. I'll have to go on take throughout my life. And in some cases, they even come up that I am fed up of taking allopathic medicines. Every morning I have to sit with a basket, medicine 1, medicine 2, medicine 3, medicine 4, medicine 5. I want to get relief of all this headache of the medicines. You give me a medicine. People believe that homeopathy can give us a long-term cure. Homeopathy can have a permanent solution. But then comes to the nature of these diseases. In what all metabolic diseases we are hearing from the morning, I think the easiest among them is the gout. Why? Because protein is not stored in our body. But carbohydrate and fats, they are stored in our body, and as a result of that, it is very difficult to eliminate such disorders which result due to the metabolism of carbohydrates and fats. So metabolic diseases nowadays, what have we seen of the COVID pandemic? Daily numbers, 2,000, 3,000. Even our friends were playing a bet that tomorrow what will be the number of patients affected. So that was the way we used to spend during the lockdowns. But if we predict what is the number of diabetes which are being diagnosed daily, I say to all of you that that will be even more panic than what COVID did to us. Because daily, lot of patients are having diabetes. So if we can say a single definition, it is given out there, diabetes is a chronic disorder resulting from aberration in insulin secretion or insulin action or both. That is the most simple definition which I have found out. And what is the most common form of this diabetes? It is the type 2 diabetes mellitus with 90 to 95%. There are another thing regarding, as we go on further into the slide, we will see nowadays the diagnosis of type 2 diabetes is becoming more challenging, because what all criteria has been set is changing day by day. I had read a book, probably it was of Robbins Pathology, where a line was written regarding diabetes only. By the time this book reaches the press, the information provided in this book is already outdated. So this is the kind of knowledge upgradation we are going about diabetes. What most of the definitions which I am providing is as per the RSSDI and the ADA guidelines up to 2024. There may be more changes in this year. So the condition is also known as adult onset diabetes. It is an alternative name. It is the 8th leading cause of mortality, and it is also the contributing factors for the leading causes of mortality throughout the world, that is ischemic heart disease and the stroke. These are number 1 and number 2. The most important risk factor of them is, of course, diabetes. So if we see the burden, that Lancet Commission published a report that 80% of the diabetes is affected mostly in the low and middle income countries, and our country India is also one of the LMIC countries. By 2021 to 2050, 59.7% prevalence is expected to increase. As a result of that, 1.31 billion cases in 2050 is going to be prevalent, that means present in 2050. The National Family Health 5 survey, they reported a prevalence of 4.9 among Indian individuals aged 15 to 49 years, and 24.8 of individuals with undiagnosed diabetes. A significant proportion of that is undiagnosed. Then the ICMR India study survey, which was conducted, reported 26.6% of Indians above 20 years have dysglycemia, and 11.4 suffer from diabetes, 15.3 from a pre-diabetic state. So if we see the 2024 picture, that is the International Diabetes Federation, where the maroon color indicates the country with the highest diabetes, and our whole of our subcontinent, especially India, Pakistan, China, USA, though Indonesia, most of the populated countries in the world, those are having the highest number of diabetic individuals. This is the number, very striking. So 32.7 million in 2000, 61.3 million in 2011, 89.8 is the last study which was published in 2024, and it is a kind of an exponential growth. You cannot pace out the difference. In 2050, 156.7 million, that is around 1.5 billion. So whenever we talk about diabetes, we talk about the risk of diabetes. Now there are certain things regarding diabetes. The first of all, many people have hypothesized that there is a certain gene in our body known as the thrifty gene. What is the thrifty gene? That our race, many times there used to be floods, there used to be famines and all of these things. Food was a kind of thing which had to be hard earned. People were very working out in the fields, working out in the forest, chopping wood, making these things and that. So as a result of that, what happened? Our genetics has been modified, where we can, when we are getting food, we can take a lot of amount of food, and all the nutrients as a result of that, carbohydrate, fats, they tend to deposit in our body, so that whenever there is a deficiency of food items, our body can get up to that. Our body can recover, make out for it. But now comes to the generation where food is easily available. People are staying in abundance. People are wasting the food. People are having lot of food. People are binge eating. And as a result of that, what happened? Our genetic structure has not been changed. And as a result of that, carbohydrate and fat metabolism is very common among Indian individuals. And not only diabetes, it is a complex of 3 conditions: diabetes, hypertension, and dyslipidemia, which forms the metabolic syndrome, or syndrome X, which is told by certain individuals. And that, what we see, people are suffering from all 3 conditions at a whole within the Indian context. People in India are not, very few people are isolatedly diabetic or isolatedly dyslipidemic, people are suffering from all three conditions together. Now, COVID-19 pandemic has resulted in a significant rise of new onset of diabetes mellitus in all age groups during the post-acute phase of COVID, and some patients, due to the excess use of dexamethasone, they have also developed hyperglycemic state, which has persisted from that period. So that has also been seen. 14.4% of new onset of diabetes mellitus among the hospitalized patients. So we have a red zone, that is the non-modifiable risk factors. We cannot do anything with them. We cannot change our race. We cannot reduce our age, which would have been a very nice idea, because there was a movie in Bengali where two persons, they were asked to commit the crime because the person in front of them told them that I know a formula by which your age will reduce down. So that is not happening in our case. We don't have any formula. So age over 45 years, family history of diabetes, what is there we have to carry in our family, and history of gestational diabetes. This is very important because most of the cases of gestational diabetes, after pregnancy period is over, blood sugar again comes down to the euglycemic state. But after 45 years of age, most of the cases, they tend to develop full-blown diabetes. And what are the modifiable risk factors? The blue things are in our hand. Physical inactivity. We have a very busy lifestyle. I also raise my hand that I perform yoga only on International Day of Yoga. So this is one of our modifiable risk factor which should be modified. High body fat or body weight, high blood pressure and high cholesterol, these all are the modifiable risk factors. Now, as per what is the diagnostic criteria, this should be very clear. HbA1c more than 6.5 is type 2 diabetes, below that is not. Fasting blood glucose more than 126, 2 hours postprandial glucose should be 200 milligram, and random glucose more than 200 milligram. This is the available in any guidelines throughout the world. Every country has adopted the American Diabetic Association guidelines regarding to this. How can we diagnose? If a person is bringing only one fasting blood glucose report, is it sufficient? No. At least 2 of this has to be performed on the patient in order to confirm that the patient is suffering from diabetes mellitus. Next comes to the pre-diabetes. Now, many people, whenever I go to talk with some people from conventional medicine, they tell us that you are a champion in this part. Homeopaths are champion in this part. Homeopaths can tackle pre-diabetes, pre-hypertensive type of early dyslipidemic state. You all are champion in this part. You should work more on this aspect. So pre-diabetes, also previously known as impaired glucose tolerance. So impaired fasting glucose from 110 to 125. But remember, these are mostly standardized tests which are tested based on the hexokinase method. And if we go back, we can see that NGSP certified and standardized DCCT assay that is done for the case of HbA1c. So impaired fasting glucose 110 to 125, mostly by the hexokinase method. 2 hours plasma glucose with 75 gram oral glucose tolerance test. This is the ideal way, because most of the cases we tend to tell the patients that you go and take a full meal. But if you have any confusion despite that, because in many cases I have seen the laboratory report comes out that the fasting blood glucose is more than the PP blood glucose, because the patient may have not taken the medicine or the food. So the best thing is to go for 75 gram oral glucose tolerance test, which gives the best result, 140 to 199 mg per dl, and HbA1c 5.7 to 6.4. This is the criteria for pre-diabetes. Now, again, let us come back to the interaction phase. So I would like to ask, what symptoms have you all found regarding diabetes mellitus? Sir, any symptom? What symptoms have you found about, sir, about diabetes mellitus? Anything? No, classical symptom is not found. Associated symptom, what you have found? Early cases? Burning soles and palm, madam. Neuropathy. Itching, where? Pruritus vulva. Fungal infection. Opportunistic infections, it comes much later when the advanced stages, when there is immune suppression, we can find it. Anyone? Healing time, yes. Huh? UTI and
Recurrent carbuncles.
sleep disorders and constipation and huh? Craving for sugar. That may happen, sir, because in most of the cases, someone who has an increased blood glucose, the family members stop them giving them any kind of sweets. So in many cases, what I have seen, people go outside and in absence of the family, they hide and eat the sweets from the different shops. So that is also a thing. Any other things? Huh? Blood vision. The most funny part about diabetes is any symptom you can imagine it can be associated with diabetes. Any symptom you can imagine from the head to the toe, any symptom can be associated with diabetes. Hair fall also can be associated with diabetes. Most common what happens, because musculoskeletal disorders is very common in our OPDs. It is osteoarthritis, low back pain, cervical spondylosis. These are most common. In most of the cases, we perform a routine blood test, fasting blood glucose, PP blood glucose, they're showing aberrations, they're showing diabetic, they're showing dyslipidemic. So this is the most common presentation. Our teachers, especially when we were in our student life, used to tell us that any case which you are finding difficult to treat, which is not getting well under your treatment, first test the blood glucose of that individual. First test the blood glucose of that individual and see, because even the simplest of the disease, a simplest of a cut, what sir was saying, delayed wound healing, a simple of boils, they also tend time to recover in cases of diabetic individuals. So whatever has been listed by the authorities, because when we are making a document, we have to keep all the authoritative statements. So in that case, I have given that incidental finding is during routine checkup, pre-surgery checkup, or any other medical procedure like extraction of teeth or something, people are conducting a blood test. Classical presentation is very rare. What is the classical presentation? It is mostly seen in type 1 diabetes. It is mostly seen in type 1 diabetes. Type 2 diabetes, classical presentation is very rare, but mostly seen in older individuals. Fungal infection, blurred vision, delayed wound healing. These are the classical signs which arises a doubt in the minds of the physicians that this can be a case of diabetes, because most of the cases in fungal infection, tinea corporis, is very common in the damp portions of the eastern, southern, western parts of the country. Dry areas relatively have lesser incidence of tinea, but in the wet portions of the country, tinea is very common. So if tinea is occurring, people are suffering for a lot of time in the tinea cruris or corporis, anytime, even capitis also is very common. Macrovascular complication. Now classically, we used to know about the complications of diabetes mellitus, that can be classified into macrovascular and microvascular. Microvascular, eye, nerves, neuropathy, then about the nephropathy. These were the microvascular complications, and macrovascular were coronary arteriosclerosis, diabetic foot ulcers. But nowadays, in a recent paper by the Nature Reviews, they have given up, they have told about emerging complications, and everything other is a part. Non-alcoholic fatty liver disease, cancers, pancreatic, colorectal, hepatocellular, breast, endometrial, any kind of cancer may be a complication of diabetes mellitus. Non-alcoholic fatty liver disease, cirrhosis of liver, obstructive sleep apnea. Many people complain, a little overweight individuals, they complain of loud snoring in their sleep. That may also be an initial presenting sign for diabetes mellitus. Also affective disorders, dementia. Affective disorders means mood disorders. That may be anxiety, that may be depressive disorders, mild to moderate, major depressive disorders. Person is not feeling well. A person does not want to go to work. Previously he was very active, but suddenly he developed a loss of interest in his work. That may be an indicative sign of diabetes. There may be a psychological aspect to it, but we often tend to overlook the physical symptoms when it is associated with the psychological symptoms. So affective disorders, dementia, people are making silly mistakes. What is the date today? Where do I live? Which road did I came from? When did I come? Today is Sunday, Monday. These all are the initial things. Mild cognitive impairment is the initial things where people make very mild mistakes. This should be differentiated from normal aging, because normal aging can cause a certain kind of mental, some memory problems. But that is slightly exaggerated in mild cognitive impairment or MCI, and that is more exaggerated when it comes to dementia. Then comes erectile dysfunction. This is another thing, and many people in the late 35 to 45s, they come to us with this kind of complaint, and in many cases we are finding that the patients are suffering from diabetes mellitus. Functional disability at workplace. One patient I remember very recently, he was dozing off very frequently in his work. Means he's working as a cashier, he's going to sleep, increased sleepiness. So when again tested, it came out positive for diabetes. So these are the different types of clinical presentation. So these are the traditional complications, that is vascular disease, retinopathy, cardiomyopathy, nephropathy, neuropathy, delayed wound healing. And this side is the emerging complication, that is neurodegenerative disorders like Alzheimer's, Parkinson's disease. Nowadays, if you can see that previously the incidence of Parkinson's disease was very less, but nowadays Parkinson's disease incidence is increasing. One of the contributing factors is diabetes. Liver disease, that is non-alcoholic fatty liver disease, steatohepatitis, liver fibrosis, cancer, as well as sleep disturbance, because OSA, obstructive sleep apnea, is a larger town or something to get tested. So that is a difficult part regarding this fasting insulin level or any kind of hormone assay, because that has to be tested in a certain time. Electrolytes and serology, that has to be performed within a certain time, and even they are transporting. If the cold chain is not well maintained, that becomes a big issue out there. In the serum, these are the main points. Next comes another important thing, MODI, matured onset of diabetes in young. And nowadays, it is confusing a lot between type 2 and the matured onset of diabetes in young, because 25 to 35 age group, even below 25 also, we are finding new cases of diabetes which are being repeated, or they are coming as a result of this incidental discovery. Onset at the age before 25 years, impaired serum insulin levels, usually obesity is not coexistent. Obesity is not coexistent, and we should remember nowadays lean diabetes and lean NAFLD is becoming a very important entity, because insulin resistance can be observed in individuals despite of their body structure. A person who is very slim can develop diabetes. Not always overweight may be the only cause. Person who is slim also can develop. Then diseases of the exocrine pancreas like pancreatitis or trauma, that may result in hyperglycemia. Hyperglycemia may also come due to stress like hospital admissions, burn injuries, All of these things may result in hyperglycemia. Certain medications like glucocorticoids, dexamethasone, all of these things can result in hyperglycemia. Acromegaly and Cushing disease, these all are the secondary causes of diabetes or hyperglycemia. Now the preventive management, obesity, whom should we target? Obesity or increased BMI, we should ask the individual to reduce their BMI. A targeted 7% weight loss yearly with the physical exercise should be done. Individualized low calorie diet plan, lifestyle or behavioral changes, and whenever as doctors we get the opportunity, we should screen the individuals for diabetes. Everyone is saying, ADA is saying, RSSDI is saying, screen for diabetes. Person 18 years and above, at least once a year, 18 years and above, person with high BMI, woman with history of gestational diabetes, first and second degree relatives with diabetes, hypertensive individual, any kind of sedentary lifestyle, and signs of insulin resistance, natramute, cicalicor, sepia, opium, and argentum metallicum. Because in certain cases, I found that argentum metallicum, especially with joint disorders, throat disorders, those are very useful in diabetes mellitus. And in cases of mother tinctures, I have given Abroma augusta, which is given Olat Kumbal, many people say. Syzygium jambolanum, most commonly used. Gymnema sylvester. Clark says that giving the Gymnema sylvester in the mouth, you cannot feel the taste of sweet or bitter. That is the only indication that is given of Gymnema. Cephalandra indica, and sometimes pancreatinum. Now the recommended lifestyle and diet. Now I find a very difficult part here, because especially I belong to the part of the country where people love to eat. They love to eat their mishti, they love to eat their mangsho and all of these things. So even if I ask people have millets, they will first say, what is millets? It is a thing to eat or something like that. So we have to respect the culture. We have to respect what is the attitude of the person, because the most important resistance what we find in lifestyle interventions is how much motivated the person is to do the lifestyle investigation, lifestyle interventions. So this becomes a very important part. We have to give them the concept that you have to avoid the main things. What things we have to avoid? First thing is which is high in fats. Fried food, packaged food, these are the most important thing, and free sugars, free salt. What is free sugar and free salt? Anything sugar that is added to any food is known as a free sugar. Any salt that is added extra for taste is the free salt. Free sugars, what are the natural sugars that is available from the fruits, vegetables, seeds and all of these things. Anything added to that is a free sugar that should be avoided. Any kind of fried packaged food, especially those having trans fat, should be avoided. As well as that, what we have to do, a diet rich in fruits, nuts, leafy vegetables, fibers. Fiber is the most important component of the diet which should be given in cases of lifestyle disorders, low fat dairy, unprocessed vegetable. Change in the eating patterns should be advised. People should be advised to take early dinner. This is a very important thing. Even certain people say that we have to eat within 6 hours. Our all meals should be within the 6 hours of the day. Extreme diet like low carbohydrate ketogenic diet must be planned and should not be given by us. Let the dietitian train for it. And sometimes intermittent fasting also helps in the reduction. Within 6 hours, breakfast, lunch, dinner should be taken. That is the recommendation by RSSDI as well as ADA. 18 hours we have to get for intermittent fasting. That is the best practice, but it is not possible for all of us. Physical exercise, it can be, we can ask the person to change or do different things. One day yoga, one day get out for a cycling, one day get out for jogging. So more than 30 minutes of moderate intensity aerobic exercise, 15 to 30 minutes of work related activity, 15 minutes of muscle strengthening exercise. This is very important because in most of the cases, those who do exercise, they tend to develop a belly and all the muscles in our Indian population, they tend to wane out. So muscle strengthening exercise is important. 5,000 steps, all are having smartwatches, fitness band that must be used. Patient activity must be included on the basis of patient willingness and ability. That is the minimum 150 minutes is recommended, but again on the patient's willingness. Processed gain, maida, ये सब बंद. Intake of red meat must be limited. Fat should be less than 30%, but it should come from nuts and seeds. Saturated fats like butter, ghee must be limited to less than 10%. Hydrogenated vegetable oils, re-cooking or refrying of oil should be avoided. Sugar intakes maximum 6 teaspoons per day. And I think that makes kind of put a smile to the face of the diabetic individuals. 6 spoons of sugar, they will be very. Salt intake less than 5 grams, artificial sweetener, sugar-free, no, 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 no. A totally big no, because that alters the gut microbiota and causes other problems. Okay. Smoking cessation, sweetened beverage must be a thing. Referral criteria, all macrovascular things and complications, that should be referred. Level 2, we are having a better facilities if there is electrolyte analyzer, urine testing, electrocardiography, chest x-ray. All of these things they are having in the second level in the CHC or the district hospital. That can be done out here. Important thing, hypoglycemia episode is very important part, and hypoglycemic episodes are very frequent in persons who are suffering for a long time, as well as persistent hyperglycemia. That means even after having allopathic medicines or other conventional medicines, the sugar is not getting control. Previously it was in control, again it is rising out and getting out of control. People are shifting to insulin therapy and all of these things. So these are the certain medicine, lactic acid, Rus aromatica, uranium nitricum, very important, having gastric disorders associated with diabetes. Helonius dioica, very good medicine if you are prescribing. Manganum aceticum, skin disorders associated with diabetes. Chionanthus, mainly which is associated with liver complaints. Aurum metallicum, associated with atherosclerosis and all of these disorders. Fasciola nana, plumbum metallicum and all. Non-responsive to treatment, we can refer it to level 3. And level 3, we are having all ultrasonography coronary angiogram in the medical colleges and hospitals where it can be, including a psychological assessment by a trained psychiatrist or a psychologist. Uncommonly prescribed medicines to ease the pain and the other symptoms in type 2 diabetes or in those who have not responded to treatment due to lack of symptom. Sometimes keynote prescription or single line prescriptions may help in this case. These are the certain things, curate, serum anguinally and all of these things. All are, if you are not working out, please refer to the next thing. इसमें दे दीजिए ना, वाला. Everything is similar. Because NAFLD is nothing, but it is the liver symptoms of metabolic syndrome. Diabetes, hypertension, dyslipidemia. What is the hepatic manifestation of this disease? That is non-alcoholic fatty liver disease. It is a spectrum of disorders. 9 to 35% is the incidence of NAFLD, and mostly seen in eastern and southern India as per the last INSL guidance paper. It is mostly seen in eastern and southern India. And the most important thing about this pathology again, unless you go to the steatohepatitis stage, you will not have any symptom. Fatty liver has no symptom. If we conduct an ultrasonography of all individuals within this room, 80 to 90% are going to show fatty liver on ultrasonographic examination. But symptoms develop when it reaches the steatohepatitis stage and in the cirrhosis stage. Comorbidity, what I told you, that it is the hepatic manifestation of metabolic syndrome. It is also known as metabolic associated fatty liver disease, but the Indian hepatologists still call it as non-alcoholic fatty liver disease, because there are certain other factors other than metabolism which is also causing this kind of disease. It increases the risk of carcinoma, colon, gastric cancer, pancreatic cancer, uterine, breast cancer, and also it is a precursor or risk factor of cardiovascular disease similar. Now the clinical presentation, whom shall we conduct? And clear guidance has been given. Waist circumference more than 90 centimeters in males. Those who are using pants of 36 waist size or more, please go and do it. Please go and have a ultrasonography. Those who are having an impaired fasting glucose or on medications for diabetes, hypertension more than 130 by 85, serum triglyceride more than 150, or HDL less than 40 in males and less than 50 in females. So diagnostic criteria mainly by ultrasound. If we see the most important indication, a liver function test, AST, ALT, SGOT, SGPT will be raised. That is the first indication that the patient is having non-alcoholic fatty liver disease, provided the patient is not a habitual alcoholic. That is the most important factor, because alcoholic fatty liver disease, and it is very difficult to differentiate. Some test that gamma glutamine transferase, GGT, component of the liver function test, if it is above 20, probably that is due to alcoholic fatty liver disease, but there is also evidence of otherwise than that also, because gamma glutamine is raised, people is non-alcoholic, that has also been found. So it can be graded as grade 1, grade 2, grade 3. What are the advanced tests? FibroScan, that is the most reliable test nowadays available in normal clinical pathology, and other than that, magnetic resonance proton density fraction. So this is the KPA. Less than 6 KPA is normal. These are the medicines. Phosphorus is most commonly indicated. One of the important Indian drugs, Andrographis paniculata, can be used, which is very important in fatty liver disease. And all of these things are mostly given in the repertory from which we have taken up this. 7 to 10% weight loss is suggested. Moderate intensity exercises, total fat consumption should be not. All of these things are similar to what we have found in diabetes. Referral criteria, if it is developing into NASH or cirrhosis, we have to refer it to a higher centers, or anything that is tending towards hepatic complications. Level 2, accessory comorbidities, if they are having, the cases are getting complicated, then it should be referred to the next center. These are the certain things, and if you see, as I've increased the level, the intensity of the medicines of hepatic affections are increasing. Level 3, if there is a FibroScan facility or other facilities in the district, in the medical colleges, it should be sent out there. These are the medicines which I have mentioned out here. The indications of the medicines have been provided to you in the book. So hepatic encephalopathy, portal hypertension, hematemesis melena requiring blood transfusion. In that cases, probably we have to transfer the patient to modern care. Thank you very much.
Thank you, sir.